Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care, so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was: my dad is already out of ICU but still with swallowing and speech problems. Should I request for a review of his medical records? You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer questions from one of my clients, Anna, as part of my one-on-one consulting and advocacy service. Anna seeks advice from a neurogastroenterologist about her dad's swallowing problems, and she asks what would be the next step in her dad's care based on what the specialist said. So this is actually a follow-on consulting session from last week with my client Anna. So today's question is: my dad's prognosis is poor according to the doctor, but who is really directing his care? I need help. So these are excerpts from email consulting and advocacy sessions with me and Anna. And Anna writes: Hi Patrick, this is the email exchange I told you about on the Skype message with the neurogastroenterologist who does specialist research in dysphagia. I would very much welcome your thoughts. Best wishes as ever. So here is the email. Dear Professor Back, I write on behalf of my father, who has asked me to contact you after my telling him about your specialist work in neurogastroenterology and dysphagia. My dad has been a patient at the St. Anne's Hospital for 5 months, having spent the initial 3 months in the intensive care unit. He's 76 years of age. His critical illness has been very complex and his recovery is ongoing and slow. He was admitted to ICU with double pneumonia, respiratory failure and sepsis. His condition continued to deteriorate rapidly despite antibiotic therapy and mechanical ventilation. He went into kidney failure. In early May, he suffered 7 cardiac arrests after an initially uncomplicated tracheostomy procedure. Thanks to the skills of the critical care staff, each arrest was reversed with no drop in oxygen levels. It took, however, my dad weeks and weeks to emerge from the induced coma. It was thought that he must have suffered irretrievable brain damage, not discernible on diagnostic scans. An MRI wasn't possible due to the pacemaker fitted after his cardiac arrests, so a head CT scan was done, which was normal. The clinical outlook was that he would likely remain in a vegetative/minimally conscious state. Gradually he woke up, although it took many weeks to recover from the delirium. By early this year he regained normal cognitive function. It looked unlikely that Dad would wean from the ventilator, such was the ostensible damage to his lungs. However, by mid-July, he successfully weaned from the ventilator after many setbacks and multiple secondary lung infections. The tracheostomy was finally removed. He began oral trials, but it became clear he has silent aspiration. Of course, his prolonged critical illness has left him with chronic muscle wasting. He was diagnosed with ICU acquired weakness and critical illness polyneuropathy. There are additional aspects. His vocal cords have sustained structural damage from long-term intubation. His swallow is not safe and he has ongoing bowel incontinence, which is still unresolved. Throughout his stay in ICU, my dad was fed through a nasogastric tube, which remained until yesterday, when he underwent a PEG feeding procedure to obviate complications in managing the nasogastric tube, which was displacement of tube and weight loss. My dad wants to recover as well as he can, and addressing his dysphagia and bowel incontinence is extremely important to him. Before becoming seriously ill, he was in good health, active and rarely unwell, despite having COPD. We remain indebted to the specialist care delivered by the multidisciplinary teams within ICU and beyond. The hospital have been open and honest in communicating with us that they have never had a patient like him before. His recovery from the point of no return has been remarkable for the clinicians and for us. The clinicians feel he is unique and that tailoring the right pathway for his aftercare and recovery is presenting something of a challenge. For example, he was discharged from ICU to the neuro ward, but when he developed a lung infection, it required him to be transferred to the respiratory ward. Fortunately, he is now under the care of a specialist respiratory physician who diagnosed interstitial lung disease. After commencing treatment, Dad came off all oxygen requirements and his lungs have recovered. The challenges which remain are the complexities of his current condition, which of course are shaped by the complexities of his critical illness over the last 5 months. Dad is very conscious that he is in a critical stage of his recovery, and he would really welcome perspectives on possible treatment pathways and how he can move forward. He would have written to you himself to seek your expertise and guidance, but he is unable to write well enough yet or type. We are conscious that you must have so many demands on your time and do hope you don't mind us writing to you directly. We were not sure the best way to go about it. If you offer private consultations, patient case reviews, we would be very keen to seek your expert opinion. For information reference, I attach copies of the 2 video fluoroscopy procedures done with Dad's full consent. The clinical team are considering a head MRI, but tell us they are cautious to proceed unless the benefits outweigh the known risk. With many thanks, yours sincerely, Anna Ward. Here's my response. Hi, Anna. Apologies for the slow response to your last email. As you can imagine, both being a clinician and an academic means you are almost 2 weeks behind the curve on everything. Thank you for the summary of your father and the copies of the VFS reports enclosed. The situation, as you mentioned, is very complex with overlapping comorbidity, all of which can interfere with safe swallowing. I note the video fluoroscopy swallowing reports showing primarily a pharyngeal problem with presumed reduced sensitivity and significant weakness plus the vocal cord paresis. It would not be unusual to see this type of picture in a post-ICU patient with possible hypoxic brain damage, CIPN, myopathy, and the diagnosed concurrent lung disease. Given the multifactorial nature of the problem, a single solution is unlikely, and I will also be honest and say that the prognosis in terms of swallowing recovery is not good. Moreover, in terms of recovery, the longer the dysphagia persists, generally the poorer the response to treatments. Most of the neuromodulation therapies which I have been involved with and have researched remain experimental, are unlikely to impact on this level of deficit. Intensive SALT, such as the McNeil dysphagia therapy program, has shown some limited success, but is very labor intensive and relies on significant amounts of cooperation and compliance. However, your father's SALT team may want to explore these options further. As you might be aware, I've been heavily involved in the development, study and commercialization via a university spin-out of pharyngeal electrical stimulation, mainly in stroke patients. I should also emphasize this as a declaration of conflict of interest when discussing your father's treatment with you. However, there are some groups in Austria that have attempted to use this technique in post-ICU patients with dysphagia with some success. These have been mainly open-label studies, so there is very limited evidence that would be considered of a high quality. However, given your father's situation and the lack of any viable alternatives, I would propose that if you can access a center that has this technique, this is perhaps considered. Unfortunately, very few hospitals in the UK are using or have access to the technique, given the limited evidence base, costs, the current lack of NICE guidelines, and the general slowness of adoption in the NHS environment. Even I don't have direct access to it in my own hospital. However, I'm aware that Genesis Limited, the company that sells the product, offer a free tester pack for trial by clinicians across the UK. I'm not sure if the clinicians and therapists at St Anne's Hospital would be willing to consider this option. If they are, I can pass your details on to the company. Unfortunately, I don't do any private practice, so it's very difficult for me to offer any face-to-face examinations. I hope this brief summary is of some benefit, and I wish your father and your family all the best in this recovery. With regards, Professor Back. Okay, so let's move on now to one of my responses to Anna. Hi Anna, the delay in giving insulin when feeds have been stopped is due to the hypoglycemia, which is low blood sugar. When nasogastric feeds are being stopped for diabetic patients, sugar is likely to go down, not up. Hyperglycemia means high blood sugar. The delay in giving his anti-diabetic tablets like the metformin in particular might have increased blood sugars in the short term, no question about it, even in the absence of feeding. However, not feeding at all for long periods, which has been the case, also has the risk of low blood sugars over time. Your dad basically had no nutrition for up to 24 or even 36 hours from what I've seen in the previous notes. This is dangerous for anyone, let alone for a diabetic. A diabetic patient can have erratic blood sugars at the best of times, let alone during a time when nasogastric feeds are not given consistently. That means that both ends of the spectrum, hyper and hypoglycemia, are a concern from my perspective and experience. Normally, after or during critical illness, insulin is a temporary treatment option and not permanent. I do remember your dad being on steroids, therefore his sugar level baseline might have been elevated because of the steroids, potentially triggering the need for permanent insulin. You should certainly ask the endocrinologist and the diabetic nurse what they think is going to happen long term with your dad's insulin. Also ask the dietitian. You are also saying that speech therapy have fallen away on the premise that they couldn't do any more until nasogastric tube is removed and the MRI is done. Anna, I can't see how that could impact on your dad not having any speech therapy. It sounds to me like speech therapy might be out of their depth too. It takes a very experienced speech therapist treating tracheostomy or former tracheostomy patients. Not too many have those skills. It looks to me like it's been too difficult for the whole treating team and they are all overwhelmed and potentially out of their depth. This whole nasogastric tube issue looks really amateurish to me, and it shouldn't have happened in the first place. Having an X-ray almost daily due to a nasogastric tube dislodgement is dangerous and has potential negative side effect. If your dad can't dress or wash himself, it might be too early to go to rehab. How can he get there? The physios need to make a plan to continuously moving him forward and keep up the mobilization schedule. Overall, it definitely sounds like a cop-out. At the same time, there is always a chance for your dad moving forward at his own pace. I believe he's definitely moving forward, just slowly. As far as the catheter is concerned, it's a clear infection risk. By the same token, taking it out and your dad potentially becoming incontinent might trigger skin irritation as well as the need for nappies. Does he wear nappies at present due to bowel incontinence? Who is the team of 3 you are referring to? Doctors, nurses, speech therapy or physios? Who's in charge anyways? I have read Professor Back's report and I'm not surprised that he suggests poor prognosis. However, he also suggests that experimental treatment might be beneficial. From a practical point of view, I strongly feel speech therapy needs to recommence as soon as possible. Another option might be to seek a private speech therapist who has experience with post-tracheostomy swallowing and voice recovery. Those speech therapists would be out there somewhere, however, probably are rare to find. Experimental treatment such as what Professor Back is referring to with McNeil dysphagia therapy program could be an option. If you Google the term McNeil dysphagia therapy program, you'll get some information. As I mentioned before, with a PEG in place, they might think that nutrition is now taken care of. However, therefore, they neglect the swallowing aspect as well as the voice recovery. Swallowing and voice recovery take specialist skills when working with patients. I can see that they don't have those skills in this particular hospital. Exercising your dad's swallow as well as the voice daily is important, and it sounds like it hasn't happened. Normally for voice recovery after tracheostomy, the speech therapist goes through a set of training exercises with patients, and again it takes a highly skilled speech therapist that is persistent as well. The many secretions he has could be from potential neurological deficits. The question most important to me really is, who is directing his care? Does anybody have a plan? What needs to happen, what, when, and by whom? Also, have you looked at the rehab facility? Is this within driving distance for your dad's wife? Also, once you have the doctor's notes, you might find information documented that is useful. So this consulting session will continue next week. Look out for it. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power and real control, and how you can influence decision making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests. How to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation fast. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind the scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into today's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also check out our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site intensivecaresupport.org for families of critically ill patients in intensive care. You can also call us, find phone numbers on the top of the website at intensivecarehotline.com, where you can also check out our ebook section, and you can get one-on-one consulting and advocacy with me over the phone, via Skype, via Zoom, or via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.